dear patients and esteemed representatives of our patients, dear esteemed and valued interested parties, we warmly welcome you to the second part of our interview on the in-depth highlights of this year's European Society for Medical Oncology, which recently took place in Barcelona. I am Michaela Neuenkirch. I am an advanced targeted therapy lung cancer patient with non-small cell lung cancer, which is mutated. In this part of the current ongoing, detailed and comprehensive scientific research and analysis, we specifically focus on a study for non-small cell lung cancer at an early stage and without any known genetic mutations, and a study on stage 1 to 3 small cell lung cancer. I am very pleased to be able to do this again this year with the renowned and esteemed Professor Bleckmann. Professor Bleckmann, who is a well-known expert in his field, is the director of the West German Cancer Center in Münster and head of the Internal Medicine Oncology Department. She and her research group also conduct research into tumor progression and metastasis and teaches medical oncology at the University of Münster. Hello and welcome, dear Professor Bleckmann.
Hello, dear Michaela Neuenkirch. I am just as happy as you are to be doing this with you again. A warm welcome to you too, dear patients and dear esteemed patient representatives and dear interested parties. We have selected 2 exciting studies for you. I would suggest we start directly with the first one, which we can then look at and then discuss together. Here is the obligatory disclaimer and my potential conflicts of interest, which in no way influence the composition of the slides. And with that, let's take a look at what we have brought. We will first go to the small cell lung cancer in the early stages. So the topic here is SCLC, and we have brought for you the ADRIATIC study, which we have already seen at the ASCO this year, and which has just been presented again at ESMO. What kind of study is this? I have already said it. An early lung carcinoma, small cell, a particularly difficult patient group to treat. Stage 1 to 3, which can be treated with standard radiochemotherapy, i.e. a combination treatment. And here the question was whether they would benefit from further treatment afterwards. And you can see this shown here again in the design. So we have SCLC patients in stages 1 to 3 who have undergone radiochemotherapy plus or minus prophylactic cranial radiotherapy, which is also the standard for small cell cancer. And then if they had no progression after radiochemotherapy, they had immunotherapy with durvalumab, which is a checkpoint inhibitor, or placebo, the primary endpoints being overall survival and progression-free survival, i.e. survival without progression of the disease. Here you can see it again, these 2 arms. And perhaps as a brief comment on stage 4, i.e. extensive disease, small cell immunotherapy in combination with chemotherapy has already been included in the treatment landscape. In the early stages, immunotherapy is not yet the standard of care for small cell cancer. That's why it's an important study. For non-small cell cancer, there is a lot, but for small cell cancer, this was the first study here that was able to show us this. And we have already seen at ASCO that this study is positive, which is groundbreaking because it was convincingly positive, and the effects seem to be significantly stronger than what we know from stage 4. So that surprised us all very much and is, of course, very positive for the patients. And here at the ESMO, it was once again a question of which subgroups benefit in particular. And the question was once, does cranial irradiation have an influence? Which chemotherapeutic agent plays a role here? And does it make a difference if I irradiate once or twice a day? These were, so to speak, the main subgroups that have been analyzed. And we'll just have a look together. Here it is now shown for with and without cranial irradiation. And you can see that in principle, both groups benefit from additional immunotherapy after radiochemotherapy. So that is the first important message for you. So the benefit is independent of cranial the irradiation. Here you can see this for overall survival and here for progression-free survival. And in addition to this, we haven't gone through everything specifically. We also have these effects independently of the platinum. There is even a tendency with the carboplatin to be slightly better. And we also have the effects regardless of whether radiation is given once or twice a day. So the message is that every subgroup benefits from the addition of immunotherapy after definitive radiochemotherapy in small cell cancer. We have not yet approved the medication, but from my perspective, it is a situation with such good data that when we discuss such patients in our tumor conferences, should apply for a hardship case once the radiochemotherapy has been completed and the findings are not progressive, that a therapy with durvalumab, which is available on the market should then be used. So this is a brief conclusion. So yes, immunotherapy in the early stages of small cell cancer with this study is set in my views. We are waiting for approval and the data are so good that we can apply for it.
Yes, thank you. I think that is very good to hear because, as you have already mentioned, it is not that easy to find a good and sustainable therapy for small cell cancer. You said earlier that this is used if there is no progression after this radiochemotherapy and after potential radiotherapy. What does that mean? If there is no progression, often after direct progression, you can then say, okay, there is progression, we can't use this, or do we wait a certain amount of time? How is it defined that there is no progress so that this combination can be used?
Yes, exactly. That is a very important question. Thank you for raising it again. So that means when the radiochemotherapy is completed, we have a new imaging procedure, usually with a CT of the chest and the upper structure with contrast agents, where we simply compare the tumor volume now and before the start of treatment. And there are some patients, even if they are not the majority, but there are patients who are refractory to the treatment. And of course, you have to filter them out because immunotherapy alone cannot control a tumor that is growing, especially not in small cell tumors. And that's why it's outlined like this. But there is no defined time window. I would say between 2 to 4 weeks after the end of radiochemotherapy, these images should be taken. And in this setting, simply to filter out those who really haven't benefited at all, you can give this treatment.
That is important. This is, of course, also important for patients to know, just like what you said, that hardship applications can be made in such cases. I think these are two important, as they say, take-home messages for patients that they can keep in mind when talking to their oncologist. I would also be interested to know that lung cancer patients in general often have great reservations about prophylactic whole head radiotherapy, but you can also see here that this definitely favors the therapy. If the skull has been irradiated, can you allay patients' fears, or what do you say?
Yes, that is a very important topic. So let's take a quick look to the biology of the small cell. In terms of the way this tumor is structured, it doesn't have much to do with non-small cell lung cancer because it is a very, indeed, rather aggressive tumor disease that is characterized by very rapid growth and also by very early metastasis. In other words, prophylactic cranial irradiation is so important because even the smallest tumor cells may have settled in the central nervous system, but you can't see them and the irradiation already has a therapeutic effect. So that's how the small cell tumor came about in the first place, which you would never do with other tumor entities. First of all, it is fundamentally due to the biology of the small cell lung cancer that we have such a treatment regime at all. Of course, whole brain radiotherapy, the radiotherapist won't like to hear this now, also has its side effects, especially in terms of quality of life. So in principle, you can think of various scenarios. So for patients where it is not possible for them to have MRIs of the head at close intervals, because that means the follow-up care for the small cell, an MRI of the head must be included regularly. If you can image this well, you can discuss whether prophylactic radiation is necessary, because then you could also use it if there is something in the image. But if this is not reasonably possible, then I would argue in favor of doing it, because what you don't want under any circumstances is symptomatic CNS metastasis, and that's what it's all about in the end.
Yes, thank you very much for explaining that again, because I think the better patients understand what goes on in an oncologist's mind when recommending treatment, the better they will be able to give their consent for such treatments, which can affect their quality of life.
Absolutely. And you have to discuss the options together with all the pros and cons and then decide what is the best way forward for each patient.
Exactly. Well, yes, thank you very much for this further discussion of ADRIATIC. You are also welcome to take a look at the ASCO data, where we have already discussed the ADRIATIC study. Yes, we will then move on to our second and final study. This is again about non-small cell lung cancer at an early stage, which is operable but still untreated. And Professor Bleckmann, you can start.
Exactly, we're sticking with immunotherapy, but we're now moving on to non-small cell therapy. And I already mentioned earlier that immunotherapy has already moved in and is here to stay. So we'd like to take you with us once again. To get you started, I brought along another overview of what immunotherapy we have already approved and have boxed it here for you in red. So as you can see, we have 2 adjuvant approvals, atezolizumab and pembrolizumab. We have approved neoadjuvant, nivolumab plus chemotherapy, and we have approved perioperative, i.e. a sandwich therapy, immunotherapy before surgery, and immunotherapy after surgery based on the KEYNOTE-671 study, pembrolizumab plus chemo, and then pembrolizumab again. And we have now brought you an update on this phase 3 study, which is testing the perioperative use of immunotherapy, i.e. around the operation. This has already been approved. Here you can see it again because there was another update here. Large study, stage 2 and 3 were included, but untreated patients were diagnosed who then first received therapy, immunochemotherapy, then surgery. The primary endpoints were disease event-free survival and overall survival, and the phase 3 study, i.e. the comparison here is with the placebo, of course. Here you can see it again, exciting, important study. And if you look at it again here, the patients were generally able to undergo the operation. That is something we have always discussed. If we pre-treat before the operation, fewer patients will come for surgery. And now we have another analysis of which subgroups benefit most in terms of event-free survival. You can see this again here on this plot, and you can see that all subgroups, regardless of PD-L1 status or histology or stage, all benefit from immunochemotherapy. This is an important message, so to speak, and the higher the PD-L1 status, the better the effect, so to speak. But there are no dots over here. This means that there is no subgroup where chemotherapy alone would have been better. And the same applies in the plot for overall survival. Again, with a certain dependency, the higher the PD-L1 status, the higher the benefit. So you see here the patients with PD-L1 less than 1. These are really the ones where you might not be so convinced. Otherwise, all subgroups have a benefit here. And what's really exciting here is that we can now see again how the patients who have or have not received follow-up treatment are doing, once for event-free survival and once for overall survival, with a tendency for treatment after surgery to be positive for the further course. But that is one of the much discussed points. Who needs treatment afterwards or not? We will not be able to resolve this completely today. So one study that is positive, that has entered the treatment landscape. We have positive overall survival data here. I would also like to briefly emphasize that it is an early study, and we not only have event-free survival, but also a positive effect on overall survival in an early disease study. And it is not self-evident that we are already seeing a positive OS benefit in favor of immunochemotherapy compared to chemotherapy alone. And I would say that from my point of view, pre-treatment in the neoadjuvant perioperative setting is essential for the more advanced early lung carcinomas anyway. And KEYNOTE-671 is our only perioperative approval, and in my view, immunotherapy is here to stay. And perhaps I can also make a brief comment on what is actually the decisive factor in pretreatment. We know that patients who achieve a PCR, i.e. the tumor is completely gone when they are operated on, are the most important factor for event-free and overall survival. And what we also know is that the rate at which I achieve a PCR is higher when I have immunotherapy with me compared to when I only have chemo. And that is the justification that, in my view, immunotherapy has to be included before surgery, because whoever has PCR has the most favorable course.
I can only agree with that. I very often find that those who don't have mutations think that my options are now less than those who have mutations. And in this case, I think it's also important that even with a PDL status that is not 50% or higher, where a pretty good response to immunotherapy is assumed, but that those who don't have such a high PDL also benefit. Let's leave out those where it's less than 1%, but I think this is a promising treatment regimen for non-mutated non-small cell patients.
I think so too. And the approval is that we have it as an option from PDL1 of 1%. So that's all those with little in it. And I think this has revolutionized the treatment of the early stages. A few years ago, we had nothing at all if we think about it again. And now I've already shown you 4 immunotherapy approvals in phase 3 studies, and the other approvals are still to come. And this is here to stay and has already shown an improvement in overall survival in the early stages. And we've never seen that in other entities in the adjuvant trials for many years in melanoma or something like that. So the effect
here is really big. This is extremely important for the patients. What about the side effect profiles?
This is a very important point. The side effects of checkpoint inhibitors are very manageable. We already know this from stage 4. Immunotherapy has been around for much longer, but these are always PD-1, PD-L1 blockades. And this does not lead to a relevant delay in surgery or the feasibility of surgery. And our surgical colleagues, who we would also like to acknowledge here, say that it is, of course, different to operate on the lungs if we have had pre-treatment with immunochemo. They also see a kind of adhesion of the tissue, probably also due to this immune reaction, but the operations can still be performed to the highest quality. And that is a very important message. So it's important in terms of coordination that you discuss this in the tumor conference, of course, and also discuss how many cycles of chemoimmunotherapy we do, when is staging, when do you go to the surgeon. Of course, this is different from going from the tumor conference to the surgeon for surgery. So we have to agree and coordinate well and take the patients with us. But the benefits, so to speak, are huge.
Yes, and that is the most important message for patients, that the treatment has a lasting positive effect on the effectiveness of the operation, that there will be no relapse or relapse very late or whatever, that ideally it won't come back at all. Then, dear Professor Bleckmann, thank you very much for discussing these 2 studies with me. We both hope that the patients will be able to take something away from it that they can discuss with their oncologists, or that they will perhaps now understand some things more easily. And I can only advocate again and again that you stay in close contact with your oncologist and find out what your treatment options are. With this in mind, I wish you all the best for your treatment, and Professor Bleckmann, I'll let you have the last word.
Thank you very much, Michaela Neuenkirch. Thank you very much for the great co-moderation. It's always a lot of fun to discuss things together. We hope that we have selected some exciting things for you behind the screens and that we have been able to bring them a little closer to you. From our point of view, this is, of course, always a somewhat subjective assessment, but what we think is exciting and relevant for patients. Yes, please stay tuned. Keep in touch with your practitioners in your networks, and if you have any questions, you can certainly address them to us. Thank you very much.
Thank you very much.